our first speaker is Hayden McRobbie. Now, Hayden has a PhD in medical psychology, and he is our national champion for the Raising Healthy Children target. And he's working a lot with counties Manukau, but also nationally. So it's really great to have him here. We've got a GP, Dr. Christine McIntosh. She's a GP, but she is also the GP liaison for child health in counties Manukau. Our last speaker will be Susan Reid, and Susan is an expert in health literacy, and she's been working and focusing on this issue of obesity in children. So let's get going. So our first speaker, I'm welcoming Hayden McRobbie. Now, Hayden's going to give us an overview. So welcome, Hayden.
Thank you very much.
And fire the questions in.
Great, and I'll trust you'll give me a tap on the shoulder when we're nearly done. So I'm just going to set the scene here to start off with, and I've just titled this Key Messages, but just to get across some of these simple messages around the Childhood Obesity Plan, but also the Raising Healthy Kids target, which I'm sure lots of you know about. Now, just to set the scene for tonight, many of you know these data already, but if you're looking at kids aged between 2 and 14, 11% are obese. You've got an extra 21% on top of that who are overweight. So we're looking at a third of these kids being overweight or obese. Now, there are ethnic differences. Māori and Pacific kids are more likely to be obese, 15% in Māori, almost 1 in 3 in Pacific kids. And there's also a socioeconomic divide as well, with those from the lowest socioeconomic groups more likely to be obese. Now, in terms of health risks, I think that it's important to remember that the major health risk here is of these kids growing into overweight or obese adults. That's where we really have the biggest problem. But there are some health risks in kids, such as musculoskeletal problems, obstructive sleep apnea, asthma. And I think don't forget about the mental health issues, especially with poor self-esteem. If the kids are being teased at school, can lead to depression. I actually saw some data from New Zealand more recently showing that actually, kids, helping them grow into a healthy weight can also help them grow into, a better state of mental health.
How do we define an obese kid?
Well, in New Zealand, we use the NZWHO growth charts. And so it's not just about working out a BMI in kids as you would in adults and then applying the adult cutoffs. So as you all know, obesity in adults is over 30, a bit overweight over 25. Within kids, you have to look at their sex and age-specific growth. And for obesity, we're defining that as over the 98th percentile.
Over the 98th percentile, fantastic.
Now, as you all know, and I think you'll appreciate, that really the goal of what we're doing here is to help these kids grow into a healthy weight. This is not about weight loss in kids. We've got some time. In the 4-year-old check, which is where the focus of them at the moment is with the before school check, Raising Healthy Kids target. We've got some 14 years really to get it right and help them grow into a healthy weight by the time they're an adult. And I just want to point out too that it's not all about us as medical professionals or healthcare professionals solving the world here, because there are so many things that influence weight, environmental factors. Genes are also important, as well as the nutrition and physical activity. So there are so many things to do. The causes of obesity are complex, so the treatments are also equally as complex.
Is there a link with family income and obesity rates?
There absolutely is. So lower socioeconomic groups, both adults and children, are more likely to be obese. Now, in terms of the New Zealand Childhood Obesity Plan, this was launched in 2015. It's a package of 22 different initiatives. 9 have actually been completed now. A number of those are guidelines, for example. If you're looking at the pointy end of that pyramid, this is where the health target fits. So this is very targeted approaches at kids that are already of an unhealthy weight. Down the bottom, you've got the more broad population-based approaches, such as restrictions and advertisements, helping people make healthy food choices. Now, in terms of the goal, the ultimate goal, if you like, is really getting these children and young people living and staying well. But long term, we're looking at reducing childhood obesity in New Zealand equitably. So we're really going to have to work more in our Māori and Pacific populations. Medium term, we're about more children being physically active, more children eating well, children's environments that support them to be physically active and eat well, and of course more children having improved health outcomes. Now, I just want to touch on the Raising Healthy Kids target, and this is the process. Now, the target is by December, by next month, this year, that 95% of all kids identified as obese during the before school check will be offered a referral to a healthcare professional for clinical assessment and family-based nutrition, activity and lifestyle interventions. So this is sort of how it looks. You've got these kids going through the before school check, the nurses, the staff there are doing the measurements, having a conversation, and then making a referral. Now, many make two referrals, one to primary care, the other to a health and lifestyle support service like Active Families. And there should be some feedback in there as well. But remember that the core of this target is really to build momentum, to get these kids into a system again, and to make sure the child's growth is regularly monitored. It's one of the key outcomes we want to see with this target. And of course, also to encourage the parents to take some action.
When we say regularly measured, how regularly?
Well, ultimately, you'd want it every year. But if they're already in the overweight or obese category, you'd want to do that more regularly, so maybe every 6 months. Now, I know that might be just too much, and you have to use your clinical judgment here as well. There will be times where, getting the kid to stand on the scales and taking the height may not be the right time. But regular monitoring of growth is really important. So this is really what we're talking about with primary healthcare professionals, what they're doing. Certainly conducting a clinical assessment, and Christine's going to talk a little more about that. Monitoring the child's growth on a regular basis, and then supporting the family to make lifestyle changes. That's not you having to do all of the hard work and sit down, but I think don't underestimate the role you have in motivating change in people's health behaviour. So it's about having the conversation, explaining what the measurements mean. Talking about percentiles is kind of a bit confusing. So trying to break it down into simple language is important. Offering some support to make very simple changes. And I think if you can remember that big changes can start with very small things, and they should also all involve the changes in food, physical activity, getting enough sleep. We'll talk more about that.
Just holding in there, I've just got a great question, and this is from Rose Bruce. Having watched the last government blame individual choice, I have a feeling of despair. When I see real change, it is unique, i.e. quitting meth. Basically says these lifestyle interventions without macroeconomic measures feel like setting them all up to fail.
It's really hard for people out there, and I think we've got to take into account their lived reality. It's not that these parents are not wanting to do their best for their families. They are trying, but the situations in which they live are often, very busy or chaotic, and parents just want to make sure their kids are not hungry. And sometimes the environment just doesn't support them to do that well enough. So it's a really good point to make. I'm not going to go too much into this, but just so you know, the ministry does have a pathway that looks at the 4 steps to take in managing childhood obesity. The first is, of course, monitoring, assessment. This is about managing, and it should always be the trio of food, activity and sleep, and behavioural strategies to help cement these changes in place. And if you're a bit stuck for physical activity guidelines, these are relatively new, published this year, guidelines for young people. Top line here, sit less, move more, sleep well. And I'm going to just leave this here, and I touched on this already after that question, but I think parents are trying to do their best. Remember, there are a lot of life pressures. And actually, for many of these parents, this may be the first time that anyone has ever identified that their child is of an unhealthy weight, or even mentioned any of this. They just had no idea. I think showing some understanding of families' lived reality can really help. And I think keep in mind, the good news is we're not helping these kids broke into a healthy weight. I mean, we're not helping them lose weight. We're really about helping them grow into a healthy weight And the lucky thing here is that we have some time.
Just from picking up a couple of those issues, helping a child grow into a healthy weight is great if you're 5 or 6. What about the adolescent who's really stopped growing in height but is obese?
Yeah, and at a time of adolescence is difficult for changing a whole lot of behaviour. And I think this is highlights the critical importance of early changes and whānau-based change. It's not about one individual. It's not just about the child. It's about changing whānau lifestyle altogether. I think that's where you're going to get your biggest bang for your buck.
Someone else has asked about GPs and nurses and brief interventions, and is there any evidence that we can make a difference?
Well, there are some data that suggests that actually brief interventions for childhood obesity can work, but at the moment the effect that you give is pretty low, and some would even argue, is it clinically relevant? But I think if you go back to the interventions that we have from the smoking data, some of you know I know this field very well, it's about prompting behaviour change. Most people won't manage to do it long term, but it's about keeping on going and being there and supporting them, understanding how difficult it is. Many of you out there know how difficult it is to maintain a healthy weight and good physical activity. It takes a lot of effort, a lot of mental willpower, if you like. So just having your patients back, being there every time they come in and say, hey, I know how difficult it is, keep on going. The evidence for brief interventions for adult obesity are looking much better.
Fantastic. So that gives us a really good overview. We've had some questions just rolling in with people feeling concerned that can they access the guidelines, and of course we will be distributing or making clear on this page at the end of the talk all the resources that we discussed tonight so that you can go back, look at them and access them for your clinical practice.
And there's some great video resources on the HPA website, and we'll put a link up with that. So there's
what is HPA?
A health promotion agency. Thank you very much. Especially when talking to Pacific people, there's some really good content on there that I think you'll find really helpful.
Fantastic. Thank you. That's a wonderful overview. We think we've answered most of the questions. There is this concern about lower socioeconomic status and the pressures on that group in our community. But let's now move to Christine, who's going to talk with us about her specific cases. Hi, Christine.
Good evening. Hi. Okay, so I was quite keen to have a little bit of an introduction here, just to say the reason why we've come about doing this webinar is this is a result of planning through the Regional Child Health group and run through the NRA, and we decided it was really important to support primary care with some more education and resources. So I come from Counties Manukau, but I have had GP input into that group. I'm going to show some resources tonight that are on the Auckland Regional Health Pathway, but what I understand from Hayden is around the country, other people have health pathways or their own primary care pathways that actually have very, very similar content. So
that isn't just restricted to Auckland. So we've got a number of people from Capital Coast, and hopefully we'll be able to ensure that they've got access as well.
Yeah. So I spent a lot of time at the regional health meeting talking about what was realistic for primary care to achieve in the situation of talking about healthy weight with families that are coming in. So I think just to summarise briefly what we expect that we'd measure growth in primary care. We expect we'd have good communication skills, and Susan's here tonight to help us along with that. That we'd assess for comorbidities of an unhealthy weight. And that's really, really important because we are actually seeing children coming through the hospital system with serious complications of being in an unhealthy weight. For instance, type 2 diabetics at age 10 coming in a serious condition into hospital.
It is alarming. You're going to explore what sorts of things we should be looking for and measuring.
Yeah. And awareness of the Be Smarter tool, which we'll take you through in a moment, and negotiate a management plan and follow up. And although this looks quite alarming, I would like to take you to the web page to explain that. So do we come just through here and come to the web page? Okay, so this is the Auckland Regional Health Pathway. Hopefully you can all see it there. And we put a lot of effort into putting this pathway together. We used evidence and expert opinion to put this pathway together, and so we think it would be really helpful for you. Just to walk through with those people who haven't looked at health pathways before, there's a bit about childhood obesity there in the beginning. Practice point, really important here, and Hayden alluded to this before, BMI is not the same ranges for children as it is for adults, so it's really important that we accurately assess that, and I've got a case that demonstrates that shortly. Now, unfortunately, our medtech is not using the current Ministry of Health preferred growth charts, but you can find the right growth charts here. Look, don't get too stressed by 1 or 2% here and there between the different growth charts, but look, you can find the ones that you should be using here. But if they've come through from the before school check saying that this child is in the obese range, do believe it, it's true. Okay, so you'll find the growth charts there and determine the weight status. And then it's really important to talk through with the family about what the contributing factors might be. So here's just a prompt for things that might be contributing in the family history and things that might be important for that child. Identify weight-related problems. This is really important because children who are in an unhealthy weight may be experiencing problems as a result of that unhealthy weight. And so it's really important to sort of methodically, systematically go through and say, actually, any of these issues are a problem for this child. Take a food and lifestyle history, really important. We're pretty used to doing this sort of thing in primary care, but it's really important to actually ask about each of these things because it's not just food that contributes to being overweight, it's all those other things like the amount of activity the children are engaged in, and especially their sleep patterns. And so there's a really nice guide here to how much sleep children should have, just so that you can quickly access this during your consultation. Now, it's really important that there may be some conditions in children that may be contributing to obesity, and it's really important that you look for these as well to ensure there's not an underlying cause for that, and there are some prompts here about that as well. Now, many people say, well, should we do some investigations for children? You know, we've got undiagnosed type 2 diabetes coming through. And in the Auckland region here, we have put through a list of investigations and the ages at which you should do them. It's a pretty extensive list here, but if you work your way through for children and just decide what it is that could or should be done for that child, it's really important.
It does feel a little alarming, doesn't it?
It looks somewhat complex, but the idea is that we are actually testing before children end up in a hospital situation acutely admitted with their diabetes or with the long-term complications of fatty liver. So
the big blood tests we're doing are HbA1c, lipids, and our liver function tests.
Yes. So you can be guided here.
Do we find that many of these kids iron deficient?
Well, many children are iron deficient. Yeah. Yes.
I just wondered if there was a correlation with poor nutrition, obesity, and iron deficiency.
I don't know the exact answer to that, but yes, I know that a lot of the children in the population who are obese are
I tend to often throw in an iron just for that very reason, that, you know, it's something to identify for brain development. Yeah, fair enough.
There is also at the bottom here not just blood tests, but also the obstructive sleep apnea questionnaire as well. So the idea here is this supports GPs to be able to make decisions about what, if any, blood tests or other investigations they should be doing. So as far as management, so we say, well, what can we do? Hayden's already taken us through some things there. In the Auckland region, we have opted for the Be Smarter tool, which you will find under here as well. But it's important to initiate a discussion. Okay, so the Be Smarter tool is here. Now, if you haven't had your training and you're in the Auckland region for the Be Smarter tool, you will see just here how you can get somebody coming.
What is the Be Smarter tool and what is the evidence that it works?
Okay, so this is the Be Smarter tool. Okay, and this is the Y Kids initiative. And they have some pretty good evidence that this is having an effect. At least gives us a framework by which we can work through a discussion with the families.
What are we offering through the Be Smarter? Just generally, what does it offer us?
Okay, so I'm going to get Susan to take us through that briefly, but it basically gives us a framework in which we can have a discussion and talk about goals with the family about ways to achieve a healthier lifestyle. So it talks about nutrition, it talks about having water, it talks about having enough sleep, and less device time and so forth like that. So it gives us a really good framework in primary care. But it's really important that you do get the training in how to use that tool in your practice. So I do encourage people.
Nurses, pharmacists.
Yes. So in the Auckland region, this is the list here of the people that you can contact to request that training occurs.
Fantastic.
Okay, so it's quite an extensive pack to go through with the Be Smarter tool about the training. Not that extensive, but it's really important you do have the training for it, and you'll be given the pack at that point in time.
I've actually had on that issue a nurse write in and say, do you have access to the health pathways? You should have access if you've got medtech, and I'm not too sure with the other IT products, but certainly any health professional has access to these pathways.
Yes, so you should have access for your region. So if you're in the Auckland region, it should sit on your dashboard, or it should sit somewhere in your medtech or your My Practice to get access. Okay, apart from that, the other useful things on the pathway is knowing what activity and nutrition programs you have in your local DHB. And for the Auckland region, you can see we've literally made a list of all the activities here. And really importantly, Healthy Families is on this list too, and how to contact them. Okay, now it also makes sure that you've entered the correct read code in primary care. So just allows us to monitor how many children are having issues with their weight, and actively recall once you've determined a child's in the obese range to make sure that you're reviewing things. Okay, in the county's Manukau area, you may choose to put this child under plan, and the family and whānau around them under a planned proactive care approach can be really useful. Okay, the following section is just when you may request additional support. And in general, the health system cannot manage to see every child who's in the obese range clearly. And so it's really important that we're doing things actively in primary care to make sure there's not any comorbidities and that we manage things as much as possible. But obviously, if we determine there may be a problem, then we refer through.
When do we know that we should refer to a dietitian? And if we do, how long is the wait currently in Auckland? And I mean, I'm sorry, I can't talk about other regions because we're both Auckland based, but I'm sure it would be interesting to know in other areas.
So the reality is the dietitians, if they do exist for this purpose in the DHBs, would be overwhelmed if we sent every child in who was overweight or obese.
Yeah.
And that's the reality of it.
Yeah.
And so it's really important that we do rely somewhat on the resources that we do have available here, and ensuring that our practice nurses and our GPs, have read around this and know something about it. Okay. But the focus is not just on diet. Okay. And that's really important. It's about having a healthy diet, but it's also about that activity, the sleep, and so forth. It's really, really important. Okay.
So that's the dilemma for us out in general practice. I mean, depending on where you're working and where you're based, and I don't know who knows the answers to this, but I guess the question is that you've got all these children, some of them we can manage. But if I had a child who was 10 with type 2 diabetes, I would actually want a dietitian involved.
Absolutely.
When we've got significant comorbidity, I think that there should be places.
Absolutely. No, and in that example, when you've actually got a comorbidity that you've recognised as occurring, absolutely, that's an absolute course, refer that child through. Okay, and there are dietitians who can work with that family in that situation. But when you don't have comorbidities, it's preferable that we manage these children in primary care, and that's what we're trying to support through the pathway, to understand, are there comorbidities, are there not? Okay, and that's the reason for that, because we realise the DHBs, the health system cannot cope with a large number of children coming through, but yes, those ones that do have the comorbidity is really important, especially diabetes. Okay, so I just wanted to quickly go to the information. Look, there's really good resources here in this health pathway. This is your clinical resources. Then we also have patient information. So these are the ones that have been vetted by the dietitians in the Auckland region, and these are the ones that have been decided as really helpful for families. Okay, so they're things that you can print, websites that you can direct families to. Okay, healthy lunchbox options, gives you immediate access to really good resources. Okay, and these are your references here. So yes, quite an extensive list for this pathway. Okay, so I thought what would be really useful here is just to talk through a few cases that I've come across in working in general practice, and just talk through those, but I'm very happy to take questions along the way. So this is the first case that I've had referred to me actually as a GP liaison. I had a concern from the before school check nurses who had feedback that this child had been to the GP as they were requested, because the nurse at the before school check had determined that their child was in the obese range. And this is literally taken from the letter that went out to the GP. The BMI was 22.1. Now, when this family went to the GP said, but that's okay, that's in the healthy weight range. There's not a problem here, off you go. So this is the BMI range for boys, and this was a little boy, and this is where we put his BMI for age. So what you may not be able to quite see is the 4 years at the bottom here. So I'll just push with the cursor down here. Now, when we plot this child's BMI, it's actually somewhere up in the WHO sign. Okay, so this child is certainly in the obese range, and it's really important that us in primary care are supporting and saying, actually, yeah, make sure we actually plot this out.
Just thinking about plotting these, I've always thought about crossing the lines as always an indication of either, the health is falling away. There's a note here from a Plunkett nurse. If we are tracking these early and they are tracking up,
yes,
we shouldn't wait till they get to the 98th percentile. Crossing these lines,
and that's exactly what we're talking about. That's what Hayden was talking about. Is actually we don't wait till the before school check to be told that this child's in the obese range. This is something we should have been recognising that the child was heading towards in primary care earlier. So we need to make sure that we're measuring growth in children at regular intervals, absolutely, so that this poor family is not appearing with this child who's suddenly way above the 98th percentile. Okay, so really important, get familiar with the BMI for age and act upon these referrals, please, from the before school check. They are measuring correctly and using the right charts, okay? And it's really important that we also add the classification in our patient management systems and that we record for consultation, okay?
One of the listeners has asked us about this whole impact on insurances.
Mm-hmm.
If we say a child is obese, are we then going to, in 10 years' time, 15 years' time, hit their insurance rates?
It's a very difficult question, and I'm not sure I know the answer to that one. I think, if they have asthma, we write asthma. If they're obese, we write obese. This is actually a health condition, and
it's a real dilemma for us as GPs, and I'm totally on your side. I think we're here to provide a good and accurate health record.
That's exactly
We're not here to manage insurance policy claims, but it does raise issues, as we certainly know with anxiety and depression and other areas that we are
absolutely
being challenged by the insurance companies.
And there can be a lot of pressure to
not
document. But if we're not documenting, we're not identifying, we're not saying that this is important. So this is.
When we're thinking about these children getting bigger, we talk about them growing into their bodies, but we're also talking about them as a baby starting and getting bigger.
Yes.
What happens if a child starts on the 98th percentile and they're just a big baby and they're growing into a big boy?
Okay, so I'm really interested in this because my real passion is about infant health, babies and infants. And so I think, when a baby's born, there may be pregnancy factors coming into play here, like a mother that's diabetic, So it's important that we're actually looking at that. It's really important to encourage breastfeeding because this is the best way to moderate weight gain in children. It's by far the best food, and if they're fully breastfed, then it tends to be the best way to balance things. It's also better for mum. So Now, the other thing is that at 4 months, I quite often get a referral from the well child nurses locally to say this child has plateaued in their weight gain. And I think you probably found exactly the same thing happening. A fully breastfed child plateaus in their weight gain at 4 months. This is quite normal. Like a growth chart doesn't quite show it, but it's pretty normal, and generally they will pick up if you just watch and wait. So I think it's really important that you don't supplement up the feeds at that point in time, that you encourage and say that it's normal for babies to wake a little more often as they get to this age, the 4 to 5 months age, and keep encouraging and say this is okay, this is fine, okay? Because I think there is a lot of temptation to supplement and feed up babies at an early stage. Yeah, and I agree, a lot of the weight gain happens at that point in time in that first year of life. Okay, now this was absolutely happened. Mother got attended with her 2 children. She said, is my kid too skinny, doctor? I'm worried that they're not gaining enough weight. And she had her 2 children there, and I weighed and measured both of their children, and it didn't really take that long, thank goodness. It would have been a quick consult otherwise. And what I was able to tell her is actually the child that she was worried about was perfectly within the normal health weight range. And it was actually the other child who was sitting in the overweight range. And this came as quite a surprise to her. But it really was quite important, because then followed a discussion about, well, actually, the child who was in the healthy weight range was good at just modulating how much they wanted to eat, and they should be supported to do so. And we talked about what was contributing to the older child being in the unhealthy weight range.
It's really important we address this issue. If 1/3 of our children are overweight or obese, it's normal now.
Yes.
So we are now normalising overweight and obesity in childhood. And I think that even as doctors, I often hear doctors say, I don't need to measure weight or height because I can see it when they walk in the room. I think we have to be very careful with that, because we are now seeing and normalising a heavier child.
That's exactly right. And I think that was the key message for me out of this, was actually we're not good at predicting which child's in a healthy weight range anymore. We've become desensitized. Completely desensitized. And I've got to say, it was actually a surprise to me, this outcome as well. But that's the importance of actually using the growth chart and measuring up that BMI.
Getting a few good questions in here. Is there any role for measuring body fat in children?
No, I don't believe so. I think that it's taking it a step too far. BMI for age is a really good measure. It's got a range, and we've got to measure things. You know, in general practice, the thing we do is we look at things over time as well. And if we've measured this routinely in primary care, then we'll know what's been happening over time. We don't need to measure body fat. No, BMI for age is a really good measure. Okay, so for that case, let's routinely measure. Let's get familiar with BMI for age.
Just remind me, where do I get those BMI for range for age? They're in the pathway.
They are in the pathway. Okay.
Fantastic.
So they're there. Okay. So case 3, child attends for skin infection. So I always take this as a really good opportunity, especially if I think there may be a problem, to pop the child onto the scales, because we need to know what antibiotic dose they might need. And then this child was sitting there with his mum, who was clearly in the overweight to obese range as well. And I posed the question to them, would it be okay if we talk about your weight today? And I could not believe the response. And it was, absolutely. Yes, do you know as a family that this is something that we're working on at the moment? And my feeling from this was, number one, surprise, because I didn't expect this response. I was sort of tentatively going into this, but the response was very positive. And what followed was a really, really good discussion. Okay, and so I would say, for those people who haven't been brave enough or worry about bringing this up, look, sometimes it doesn't go well, but other times it can be really surprisingly productive. Okay.
So it's to have courage.
Have courage. Yeah, absolutely. And that was a really good brief intervention, and we didn't have to launch into a whole lot of investigations or anything like that at this stage. We just have to have that brief intervention. Well done. Let us know how you're going. Let us know if you need some support. This is some options for you. Okay. And So really from that point of view, yeah, this is the expectations in primary care. This is the essentially, I guess, the list that I've compiled of what we expect to occur, and really use the health pathways, use the resources that you have, get the teaching and the practice so that you know how to use the Be Smarter tool if you're in the Auckland region.
Just one more thing about measuring growth. We're now focusing on BMI and we're focusing on the growth charts, but what about waist circumference in children?
Okay, so that's not something that we'll be actively measuring, no. So BMI for age, absolutely, yep. So I know that that's some things that you do in adults, but children, no. Height, weight, BMI for age. Let's keep it simple, let's keep it straightforward, and let's monitor it over time. Okay, and you might need to think in your practice about how you might build the systems to do this so that it's not relying on the sort of opportunistic necessarily once you're in the consultation, but what are the opportunities within the practice to routinely measure children as they are coming into the practice.
You've raised with me, I mean, we are, in general practice, many of us are feeling quite overloaded and working hard, but we need to work as a team. And, you know, there is maybe, I'm just going to throw it out there, maybe is there a role for not just our nurses, but to get these baseline measures done by other staff in the practice so that you may have medical assistants. I'm not too sure receptionists would dive at the opportunity, but there may be other staff that can do this sort of work, just ensuring that we're getting this good baseline data.
I think that's a fantastic idea, and I think that we need to be thinking creatively about how we actually achieve all the things that we need to achieve in primary care, and I think this is a really good example of where you might utilise other staff in the practice to be doing that really, you know, preventative health care really.
I see it as a perfect situation for our nurses to be really skilled in,
yes,
and to feel confident and excited to work with our patients.
Absolutely, and we certainly see that in the Kāinga Manukau area. We see this as a really excellent opportunity for planned proactive care for children, because not only will you see the child, you'll see the whole family often in that opportunity, and it's nurse-led care. And it's just that routine, it's that follow-up, how are you doing, the phone calls, things like that that can be done to really help families and support them to make some changes. So, you know, really, really absolutely agree with you. This is about being creative about how we do our model of care in primary care.
I'm really keen, if anyone out there has a brilliant model in your practice that you want to share with us tonight, feel free to type that in, please. I would love to hear if anyone's doing anything exciting out there.
Yep, I'd love to hear that too. I'd like to hear what people are up to. Okay, so this is just the Be Smarter tool, and that really segues beautifully into Susan talking about ways that we can communicate around this issue in primary care. So
there we go. Hi, Sue.
Kia ora.
Neat to have you here. Sue is a health literacy expert, and so she's going to tease this apart for us in another step, really. So, Sue, let's hear about health literacy and how do we communicate better?
Well, I'm very fortunate. My role in Kāinga Manukau is to actually go out and visit primary care and well child tamariki to providers and the before school nurses and talk to them about how to have these conversations. So tonight I'm going to talk briefly about some things we've learned from the work I've done, and probably I probably want to start off by saying Christine talked about the most important thing that I find when I go into primary care, which is how do you have that system change and make sure you're measuring children's height? Because I often talk to nurses and we say, well, let's think about a child you saw last week, and they open up the child's record and they go, oops, we don't have the height. So, you know, that's the system change, I think, is how regularly.
Having height monitors around the practice so that they're easy to access.
They, especially if they're, you know, some character, they like them. And then I think the other thing I'd like to talk about is the systematic approach to having these conversations. You know, health professionals have conversations about lots of different things. So they talk about smoking cessation, as Hayden talked about, and then you talk about, you know, domestic violence, sexual health, lots of interesting conversations. And sometimes people say to me, oh, I feel embarrassed about having this conversation. So what I would say to that is give yourself permission to have these conversations, because by having these conversations, you're actually giving the whānau permission to actually have this conversation with you. And you might initially get a response that's not perhaps as doesn't go as well as you expect, but that's because the family might feel quite upset. You've talked about them, they feel judged about their parenting and what they're doing. So, but they'll go away and they'll think about it and understand that you're their doctor or their nurse and you care about them and you care about the health of their child. And so they'll think about and think, oh, actually, I will go back and see the doc, I'll go back and see the nurse and have that conversation, because as Christine said in that last case she was talking about, the mother was like, yes, I'm really ready to have this conversation. So don't assume that they're not ready. They may, in fact, need a little bit of time, but they will come to it.
I think the neat thing about the approach we're doing is that we're moving away from just hammering people about diet. We need so many opportunities to talk around the use of iPads and telephones, the discussions around what we call screen time, the discussions around physical activity and sleep. I mean, all these things that are so important for a healthy child. So it's not just that we're going to hammer them about not eating.
Yeah, and I think I often talk to health professionals about actually using sleep first, and it's not as people haven't heard it as much as they have heard about food and drink and activity. So if you can say to them, how's your child sleeping? I was very fortunate some months ago to sit in with the before school nurses in Counties Manukau, and they were having conversations about sleep, and it was a revelation to a lot of the families that the children were meant to be having 10 to 12 hours a night, and that was like, oh my goodness, they're having 7 or 8, and I don't know how the parents got on, let alone the children. But so I think I often recommend to health professionals that you start and have the conversation about sleep first, rather than start with something that they're expecting, which is, oh, they're going to talk about fizzy drinks or takeaways or, being more active. I think, so one of the things we're going to do after this webinar is to post some of these conversation starters. So just working with whānau in Counties Manukau, I've got some tips and ideas about what people can do. And one of the first things we talk about, particularly with the before school nurses, is do apologise to parents if they're upset. And often parents' response is to the before school nurses, nobody's ever raised this with me before. And, I say to them, just suck it up and just say, I'm really sorry that nobody's raised this with you before. We should have done that, and then move on. So, and I think, from a health literacy perspective, one of the things I like to ask families is, what do you already think or know or believe about your child's weight? Because then you'll uncover their beliefs. And Hayden talked about that a bit. If you've got families who believe that their child is a good size, then you have to think of a way of actually approaching that. Hayden talked about, making change is hard, and I think it's really important to acknowledge the smallest thing that a family is trying to do, and to take that small thing and sort of make it into something, say, look, it's really great, you're doing a great thing, good on you for trying that, I know it's hard, you're trying your best, and it's great that you're making this change. So that whole being positive and non-judgmental, and making sure that when they leave you, they feel like you're walking with them, if you like, and they, as Christine said, that you're a supporter for them with this particular effort. I think one of the things that parents do feel is when you do the growth charts, when you calculate the BMI, that it's a magical thing. It's a bit like, it happens by magic. And we hear a lot of talk from health professionals about you know, people have low health literacy, and this is a really good opportunity where you can take the growth chart and explain to the family what you're doing. So here's your child's height, and here's your child's weight, and this is how we calculate their BMI. So you're actually able to show them how you're calculating it. And then, as both Hayden and Christine have said, then say actually children's BMI is really different from adults' BMI, because we've had parents say to us, when their child's, you know, BMI is 22, oh, well, that's not bad because mine's 40. You know, so, oh, actually, that's not a comparison. You know, that's not a good thing. Actually, they're probably about the same as you if you take the ages into account. I think the other thing we've talked about a bit is to actually say, use language. Now, I've spent a lot of time, as you can see, looking at me, I've struggled with my weight my entire life. And I've had to find a way of using language, because I think using the word obese, I've had feedback from families that they just don't like that language. So I think the best way to describe it is, as a health professional, you have to find a word that's going to work for you. And what we recommend is saying is not a healthy weight. And I think by saying not a healthy weight, you're really emphasising that whole thing around it's about health. It's a health issue. It's a health issue. If we're not judging you as a parent, we're judging this child's health based on the chart. So find a word. I tend to listen to what families say, and if they say something like, you know, my child's heavy, then I would use that word and then segue into using not a healthy weight later. I do find if parents talk about their child being fat, I do say to them, depending on how the conversation's going, I'll say something like, actually, we try not to use that word now because it's a word that's used and people get teased or bullied about being fat. So we tend to talk about not being a healthy weight now. And you can see some whānau looking at you and say, I don't know where you get your language from, lady, but that's not what we use. But, you know,
but
just
there is
introducing
a lot of pressure on kids that are large. You know, these kids are already put down, often bullied, you know, hammered for being in the larger group. And, you know, my heart goes out to them, really.
I think when we talk about this at counties, the one thing I think that's really missing from this conversation, and that I think would make a huge difference to health professionals, is if we had the voices of children. If we went around and said to them, what's it like being a 10-year-old weighing 120 kgs? You know, what is it like being a 7-year-old who finds it hard to wipe their bottom? What is that like? And I think Hayden referred to the evidence that just came through, the recent New Zealand evidence that showed that when parents completed the quality of life questionnaires, they were saying my child's, you know, got a poor quality of life and they've got mental health issues. So I think this is something to remember when you're looking at that child and thinking, oh, I might skip that conversation. As you know, mine would be, please don't skip that conversation, please have it. One of the things I talk about too is, and Christine and Hayden have both talked about it, is follow up. Make sure you do follow up. Someone follows up with that family, because people need to know that you're interested, as I said before.
We've had a lovely little comment in from someone in Naomi Johnson. Thank you for that. They've used a 4-year-old ruler in Otago, Barry Taylor.
I know.
And it's got words just right, big, or too big.
Yes.
Because big's not, you know, like I remember, you know, kids like being big.
Yeah.
So that it's got not the connotation and negativity attached to it.
Yeah, I think actually I've emailed Barry asking for a copy of that ruler, so I'm interested. I've seen it in the slides, so I'm interested in seeing that. And I that's what I think. Find the language that works. But I'm now using not a healthy weight, because I've been.
We had some interesting feedback in this, and one of the things that you're talking about is getting it on the table. And I love the ideas coming in from Ellen Walker. She's got a couple of ideas. She said, who's brave enough to put the scales and a height measure in their waiting room so that patients can access this and do that if they want to, in a quiet corner? The other thing is, she said, why not have a competition so that if you're the 100th child to do your weight and height and give it to the receptionist, then you get a prize. So that there is some sort of fun around this. I don't know what you think, but I think that's quite exciting thoughts, Ellen. I think you're a bit braver than me, buddy. But
I have seen practices where they do have, the giraffe or whatever on the wall, and they do have scales. I think the most important thing is that it's done accurately.
yes.
Their feet have to be, flat on the floor and measured accurately. And I think that's the most important thing. But yes, I have seen that in practices where they do have a range of different weight and height instruments available. And you can see the kids, they go and they pull it down and do this and try and work out what they are.
Yeah.
They don't feel that they haven't got to that stage yet when they know that actually this isn't something I want to. Whereas talking to some of the school nurses, they will say they've got adolescents, as you were talking about earlier, who will say, oh, miss, can I wait to the end to be weighed? They don't want to be weighed in front of their friends.
I think there are big issues for our adolescent young women and men, boys actually.
Yep. So the other thing Christine wanted me to talk about, and again, this will be placed on the website afterwards, is the Be Smarter tool. So Be Smart is an acronym for have breakfast every day, eat 5 parts a day, sleep 10 to 12 hours, etc., etc. And so it's, as Christine said, it's a framework for going through with families around, there's a questionnaire, you give them the tool. That's the most important thing, is you give up the pen and you give the Be Smart piece of paper to the family, and they tick it either not yet, sometimes, always, mostly. And they tick it, and then you talk to them. And I think there are a couple of things that we talk about. So the 2 R's in the Be Smarter tool are both negatives. So they're reduced sugary drinks and reduced screen time. And so we often people will tick that they've reduced sugary drinks, and you ask them, oh no, we have it every day. But it's just something to be aware of. And then from there, ask the whānau what's one goal they would like to work on, and then sort out a goal. I find it's a useful, as Christine said, a useful framework. But I also know some health professionals don't like it and would prefer not to use it. And so tomorrow we're going to load up a great sheet that's from Te Awa Kairangi, PHO in Wellington. And actually it's like a poster that can be put on the fridge, and it's 5 things for kids. And you can just, you can fill that in, and again, write the child's goal on it. So it's a resource. It's not something that's sacrosanct. You can write something on it.
I think what these tools do is they make us think wider than we have done and naturally do around issues around obesity. But they also enable us, if you're thinking motivationally, to really individualize your response to the person. So you're identifying what their issue is, and you're sort of working out a strategy for them, rather than just saying, do this, do this, do this, do this, do this.
Yeah, and that's the thing, I think, from my perspective in health literacy, is that it's not the telling, it's the asking people to make,
to own it,
to make their own solutions. I absolutely agree with that. And I think you can never guess what the motivation for change will be. So one of the, when I was sitting with the before school nurses, one of the families came in, the grandmother and the mother came in, and I thought that every child would look like me. They would have obvious signs that they have a puku, and they'd have rolls of fat and things like that. And actually, I was so surprised that you couldn't tell by looking at them. But anyway, we measured this child, and she was at the 91st centile. And when the before school nurse raised it with the mother, she said, actually, I'm not surprised. And the grandmother, who turns out, she told the story that she'd had bariatric surgery, and she was very keen to work with the mother to support this child. So there was quite a big motivation to make sure the child was more active, and the grandmother was quite actively involved in care. So you couldn't tell that by, looking at the family, but, as it came out, the motivation was very strong to make a difference there.
It's tapping into the family and into the child as being their own resource, their own motivator for change. We mustn't, I think sometimes as GPs, and I think that was probably that frustration that I sensed at the beginning of this, is like, oh no, we have to do more, we have to keep changing the world. We're actually here to walk beside patients and help facilitate them to change their world. We're not here to change people, and it's to facilitate and to support them to make those changes as they choose in their lives. And I think there's a different power dynamic there.
Yes, I agree with you. And sometimes you're walking, behind your patient and giving them a bit of a push, and sometimes you're walking ahead and giving them a bit of a pull. But yeah. I agree with you that I think at the end of the day, you're not going to be with that family 24/7, so it has to be something they can do in their way. I worked with a great nurse in Mana Kids, and she had this mantra. She said we need to use gentle messages to help families do more with what they have. And I've always used that and thought about that and think, yes, what's a gentle message we can use with this whānau and say, yes, we need to think about how we can support you to do something about your child. But,
gentle message to make more. What was the second half? Because I think that's
to make gentle message to help families make more of what they have. Yes.
So it's not asking for perfection. It's saying how can we adapt what you've got.
Yeah.
Now look, we're going to present. Susan, do you have any other key messages you'd like to get across at this point?
I think there's one thing. I could hear people thinking. People will say things to you like they'll say, "Oh, my child's got big bones," or or they'll say, "My child's Māori, we're all big," or "My child's Pacific." And I think it's really important to acknowledge that and say to whānau, yes, you're right, your child is Māori or Pacific or may have big bones, but we can tell by looking at this chart that it's not just about their bones, they're also carrying extra weight as well. So how can we help their bones grow taller so they can grow into their weight? And I think those are the things, to not shy away from saying yes to families, saying yes, your belief is right.
With adults, there is a different BMI score for Asian origin and also for Māori and Pacific. What about children? Are we having to look at this differently?
Well, at the moment, we're not, as Christine answered that. We're trying to keep it simple: height, weight, BMI. But I think it's important to acknowledge when people raise that and say, yes, that's right, and this is what we've got, this is the tool we're using at the moment. And it shows that your child is, that we're not talking about often children who are a little bit, who are at the 93rd centile. We're talking about children who are way over.
Have you got any thoughts about the particularly some Asian communities where, in fact, large is good for some? Often in these young Chinese boys, I see that it's actually seen as a positive.
I think that's often in some cultures. I remember one dad I talked to, and he said his son this was his ma'a nonu. He said he's going to grow up to be an All Black. So we had to talk about that. And I asked him what exercise and activity he thought ma'a did. He was like, oh, okay. Yeah, my son watches it. I think there are lots of complexities about those things. And I think Christine said, you have that conversation about food and activity, and while you're having that conversation you find out about people's beliefs. And one of the things I found out, often nurses when I go and visit practices say to me, oh, my child's so picky, they'll only eat this and they'll only eat, can you help me get my child to eat more vegetables? And I'm like, well, there's lots of resources, as Hayden talked about on the Health Promotion Agency website, but actually I can't help you do your parenting, but I think it's really important to acknowledge what parents believe, but work with that to say your child's an unhealthy weight, not a healthy weight. So what small change do you think you can make? And as Christine said, and as you said too, that's where the Be Smarter tool or this other resource from Te Awakairangi helps in that it's a frame, and then you can work with that.
Can break out from there. I'm just going to say to you all out there, it's been a fascinating discussion, and I'm not underestimating the size of the problem for some of our practices and the potential fear factor from our angle of tackling this. But you've given us some very clear, simple advice, and I think that we need to hold on to some of these facts. Before we finish, is anyone, if I'm going to give another few minutes for people to fire one more question in if they have something. But I would like Christine and Hayden to come back and just give us one bit of advice that they have, one thing that they want to say at this point.
One bit of advice only. Okay.
Yeah, you only got one.
Okay. My bit of advice would be just to get out there and do this, but keep your conversations positive and non-judgmental. That's all your patients are expecting from you, a little bit of support. I think you'll be surprised when you start having these conversations. Most of them go well.
The reality is that most of us, well, many of us have struggled with our weight throughout our lives. This isn't easy for people. If it was easy, we'd all be skinny. So, you know, this is going to be hard. We're in this for the long haul. But I think I can't support Hayden enough to being non-judgmental, particularly of parents who often feel a bit battered anyway by life, and to be positive, because little changes are big. Now, Christine, you can start.
I think that's great. I think it's been a great conversation, and I think the main thing that I would pick up from tonight's conversation, really the main point that I'd like to get across, your next meeting that you have with your practice, put your hand up and say, what are we going to do about measuring children's growth in this practice, so that it is not landing with one person, but what is the practice plan for how we're actually going to be proactive about measuring children's growth.
And it's not just a practice. I thank you so much, the pharmacist who's just written in. You have a pivotal role in this, and we need to work together as a community of health professionals to get involved in this. And I think that maybe we do need to brainstorm, not tonight, because we all need to relax a little, but to think a little bit about how we can work with our pharmacists to do this. So I would like to thank you all for signing in for tonight. It's been a great night. It's going to be a challenge, but we're up to it. We are onto it. We can do it. We're the Nike primary care team. So, yes, thank you very much to Hayden, to Christine, and to Susan for spending time with us tonight. Thank you.